in the next 12 minutes or so, I'll walk you through where we are in the grand scheme of things with all things HCM. So this is an imaging-centric meeting as it relates to hypertrophic cardiomyopathy. If nothing else you take out of this talk is, first thing is you have to make sure you elicit left ventricular outflow tract obstruction, because if you don't look, you are not going to find, and if you cannot find, you cannot treat. This is a patient of mine, normal wall thickness. His mom was positive, gene positive for HCM, underwent surgery, and he was gene positive. He was told all his life he was anxious, and his symptoms had nothing to do with HCM because things look like that till you put him under the provocation ringer and the gradients go up to, obstruction goes up to 5 meters per second. We fixed his anxiety with papillary muscle reorientation. Only at the Cleveland Clinic you can do that. So you need to utilize all means to provoke gradients, amyl nitrite, Valsalva, treadmill, bike, even talk about politics. At rest, gradients are seen in 25% patients with provocation that can go up to 70%. So designating somebody as non-obstructive without the full extent of provocation is not appropriate. With that as a setup, what were the treatment options prior to cardiac myosin inhibitors, prior to the guideline changes, et cetera? We had beta blockers, calcium channel blockers, disopyramide. These are not very effective, really do not target the disease process, often poorly tolerated, especially something like disopyramide. I think I would only recommend that for your in-laws that you may or may not like. So really not much out there. So along came mavacamten, and we are going to talk about that. Now there's a lot of guideline changes, and we have real evidence-based medicine that we are practicing. But what has been the tried and tested workhorse in symptomatic patients who cannot tolerate medical therapy or who are too symptomatic despite medical therapy is septal reduction therapy, surgical myectomy or alcohol septal ablation. But septal reduction therapy is not a one procedure that fits all. For folks with thick walls, you do a myectomy. For folks where the primary issue is mitral valve, you fix the mitral valve. For folks, we even found out about 10 to 15% of our patients do not have wall thickness. They have some papillary muscle problems. So you get creative, and this is a surgical procedure developed by my colleague Nick Madeira to help relieve outflow tract obstruction. Bottom line is you need an experienced center with highly experienced providers. This is now dated, but still the first almost 2,300 surgical myectomies from 2002 to 2018, so a huge population. What we showed was, in our practice, isolated myectomy is not the rule. We do whatever it takes to relieve outflow tract obstruction, including work on the mitral valve and the papillary muscle. Bottom line is, earlier operation. Now the world is talking about doing an earlier operation. Earlier operation is associated with long-term survival similar to age and gender matched population. And at the Cleveland Clinic, there's no penalty for doing additional mitral valve repair or papillary muscle repair procedures. This is a prospective study I led on myectomy, which showed a 38-point improvement in KCCQ score after myectomy. So in the right hands, it really works. But where's the rub? Expert centers, they have excellent outcomes, but access is limited. The higher your volume, the lower your mortality. But in the United States, this is a paper we published 2 years ago now, 70% of surgeries are still performed at low-volume centers. So talk is cheap. We do not have enough surgeons doing enough procedures. So there is a big unmet need for therapeutic alternatives. Along came cardiac myosin inhibitors, with mavacamten being first in class, and aficamten is currently undergoing FDA review. These are precision drugs developed to work on cardiac sarcomere, where they reduce the hypercontractility of the heart of the sarcomere, and it makes the heart function much more efficiently. Both have very little arrhythmogenic potential. Mavacamten is metabolized through cytochrome P450 pathway, and aficamten is yet to report drug interactions. What's the timeline now? This is 2018 when Ben was in kindergarten, Alan Cherry, and look how far we have come. In literally 5, 6, 7 years, we have 1, 2, 3 randomized controlled phase 3 trials. We had zero prospective data, okay? So 3 on mavacamten and 1 Sequoia on aficamten. What are the primary results? This is a busy slide by design, but bottom line is the drugs, Explorer Valor and Explorer China, they were compared against placebo, mavacamten, and aficamten against placebo in Sequoia. Feel, function, and need for surgery, and gradients. So NYHA class significantly improved. Exercise capacity significantly improved. Gradients, out of the ballpark, significant improvement. And in Valor study, 8 out of 10 patients after 16 weeks who were referred for cardiac surgery no longer needed surgery. Okay? So these are placebo-controlled, solid, class 1 type data. What about quality of life? Again, 14-point improvement by a drug, 14-point improvement. TAVR is 9 or 10 points. MitraClip is 9 or 10 points. This is 14 points. We also have to pay attention to a little bit of the placebo effect, but bottom line is there is a significant improvement in quality of life. This is data from Valor at 1 year, which showed sustained improvement in KCCQ. So this is not a 16-week phenomenon. This is long-lasting. This is an echo meeting. Every aspect of echo, gradients, resting Valsalva exercise, left atrial volume index, diastology, LV mass index, significantly improved compared to placebo for both mavacamten and aficamten. Additionally, last year we presented this data where it is also demonstrating a fundamental improvement in the cardiac sarcomere functioning. So strain, left atrial strain, reservoir contraction, as well as LV strain. Everything is improving compared to placebo. These are blinded placebo-controlled measurements. CMR, again, fibrosis is stabilizing, and all the other markers, so LV volume, LV mass index, LA volume, everything is headed in the right direction. So this could serve as a potential for serial monitoring of drug therapy. What is the long-term safety and efficacy? So again, this is Explorer data, 180 weeks. The gradient remains obliterated. Patients are asymptomatic for as long as they're on the drug. Similarly, Valor, this were sicker patients referred for surgery. At 128 weeks, only 7 out of the 112 have undergone cardiac surgery. You can imagine I'm very popular with my surgical colleagues, okay? And sustained benefit. So what this has done is ACC/AHA has given a class 1 indication for myosin inhibitors in people who continue to have persistent symptoms despite first-line therapy. Now, what is the real-world data also? So the mavacamten was approved via the risk mitigation strategy program, the REMS program, because of concerns of EF drop. So this is data we presented. I presented this at AHA last year. More than 6,000. Every United States patient on mavacamten was included. Almost 2,000 patients with more than 1 year of treatment. 4% EF less than 50%, 1.5% heart failure hospitalization. So, and 52,000 drug interaction checklists completed with a 0.25% dose reduction, dose adjustment. So much ado about nothing in a well-managed, this is all comers in United States, more than 6,000 first patients. And again, similar to the trials, the gradients significantly improved, and vast majority of these patients remain significantly improved in terms of their symptoms. What's coming? Now we are entering into the era of non-obstructive cardiac myosin inhibitors in non-obstructive HCM. So Odyssey, that's something I'm leading. It just actually closed yesterday, Friday, and now we should hear some results in the next few months. Acacia is something testing aficamten versus placebo ongoing, and then there is an SGLT Sonata trial that's ongoing. So all these things are going to, again, provide valuable, high-quality, randomized controlled evidence. Where we are entering the new era is gene therapy, where we are using adenovirus infusions in gene-positive patients to potentially cure hypertrophic cardiomyopathy. And this is my nurse, Danielle, and we performed the world's first in-human gene therapy for HCM now a little over a year ago. And I shall be presenting the late-breaking stuff at ACC in a couple of weeks. I'm going to end with this case, leveraging two novel things. So at the Cleveland Clinic, we have employed AI ECG assessment for patients. Every patient gets screened for hypertrophic cardiomyopathy at the Cleveland Clinic. This is a 61-year-old executive, bouncing around in the system with symptoms, but was told it was CAD, hypertension, et cetera, et cetera. His ECG was flagged for HCM and subsequently referred for workup. His ECG does not reveal anything consistent with HCM. This looks normal. But looking at his echo, there is basal septal hypertrophy and SAM with severe gradient. We put him on mavacamten. So we took one novel technology and added another. And now this guy is correctly treated in NYHA Class 1. This is something we just published earlier, a couple of weeks ago. So to conclude, HCM is a very heterogeneous disease. We are truly entering uncharted territories with all kinds of novel therapies as well as diagnostic tools. Happy to discuss further. Thank you.